Horace Roman tonight. He is a very well-known endometriosis surgeon from Bordeaux, France. I think everybody knows him, and tonight he's going to talk about tips and tricks in surgical management of deep endo of the rectum. Horace Roman is professor, honorary professor at the Aarhus University Hospital in Denmark, and he's member of our executive board of the Endometriosis League and also member of the executive board of the World Endo Society. I think we are going to learn a lot of tips and tricks tonight. I'm very happy to have Horace Roman here tonight. Before we start, I would like to make an announcement on the masterclass, the European Endometriosis Masterclass that we would like to start in 2021. And to begin next year, we have 6 sites in 6 countries all over Europe. And registration is open now on our website, euroendometriosis.com. So you can find their masterclass in January in Duisburg, Germany, in February in Bordeaux, France with Horace Roman, in March, Bucharest, Romania, April, Budapest in Hungary, in September in London in England, and also in September in Bern in Switzerland. So if you have any questions, just let us know. And now I'm happy to present you Horace Roman. Horace, we are interested in your presentation.
Thank you very much, Harald. Ladies and gentlemen, it is a great pleasure for me to be involved in this webinar and to have the opportunity to speak about one of my favorite topics, which is the management of deep endometriosis infiltrating the rectum using the disc excision. And I will focus today the disc excision using a circular stapler because I think it is the most affordable for any endometriosis surgeon in the world. So first I will present you my my conflict of interest because I was involved in master classes and workshops organized by Plasma Surgical Olympus, Nordic Pharma and Ethicon, and I was paid for this. But in these master classes I tried to share my experience in the management of deep endometriosis. So to start, you know that usually we may find 2 types of rectosigmoid nodules, of deep endometriosis infiltrating the rectosigmoid. The most frequent type is related to a kind of nodule which infiltrates the mid or the upper rectum, but also the isthmus of the uterus and the vagina. So these nodules are easy to find at the clinical examination because they usually infiltrate the vagina or maybe felt using the vaginal, using the finger. And also they can be seen easily the ultrasound or MRI. And the second type, or what I call solitary nodules of the sigmoid, meaning that they may not be connected to any other structures, maybe with the left with the left ovary, but it's not so frequent. So they are nodules with an evolution into the lumen of the sigmoid. So they may be overlooked by radiologists, but also by the surgeons because they are located on the mobile part of the sigmoid, and they may lead to occlusions. But this kind of nodule usually cannot be removed by disc excision because they are too large. So in my presentation, I will focus on the first type of nodules, the posterior adenomyoma involving the upper rectum and the mid rectum because they are suitable for disc excision. Now let's see what is the place of the disc excision in the management of rectal endometriosis. And I can answer these questions because 5 years ago, I carried out a survey in France. I call this the France study, where I asked to all the surgeons involved in the management of deep endometriosis to count, to record all the patients managed for colorectal endometriosis during 1 year in 2015. So this survey involved 56 facilities in France, and we recorded 1,135 women managed by colorectal endometriosis. And it was interesting to see, and very satisfactory to see, that 90% of them had a minimally invasive approach. And more than a half of them, they had conservative procedures, meaning shaving or disc excision. But the number of disc excision was quite low because they represented only 7% of all the patients managed for colorectal endometriosis. And the large majority of them were here in my unit in Rouen at this time. So if you remove the patients managed by me in Rouen, you will see that the disc excision is only incidentally performed in France in 2015. And this is a pity because in my own experience, the disc excision is carried out in almost 30% of patients. So here you have my database from January 2005 when I started performing deep endometriosis of the rectum until the lockdown in March 2020. So there were 1,060 patients managed for colorectal endometriosis, and 1/3 of them had disc excision, 35% of them had shaving, and 40% of them had colorectal resection. So 60% of patients had conservative procedures, shaving of disc excision, 30% were suitable for disc excision. So I think that the disc excision may be done or is suitable in 30% of cases. But to carry out a disc excision using the circular stapler, you should be at ease with the shaving. So the shaving is an individualized procedure of treatment of colorectal endometriosis. It means that the surgeon tries to excise the nodule without opening the rectum. He can use, to do this, he can use scissors, laser, plasma, harmony, scalpel, robot. The goal is to excise as completely as possible without opening the rectum, so with a bowel conservation. However, in my opinion, the shaving, when it is done alone, should not be pushed too into the depth in order to avoid a delayed necrosis of the shaved area. So if there is an injury of the rectum, so many colleagues used to put stitches, I convert to disc excision. The shaving, when you perform only shaving, I have done it in 35% of cases. When you perform the shaving, you have a low rate of complications, and you do not risk to impair the digestive complaints of patients. So the patients were never worse after your surgery than before. However, it seems that the risk of recurrences is higher because the excision in the majority of cases is not complete. That's why, in my experience, I reserve the shaving to elderly women who may have a postoperative amenorrhea until the menopause in order to reduce the risk of recurrences. But I also perform the shaving as the first step of the disc excision, because the disc excision means that you remove not only the nodule, but you remove also the wall involved by the nodule, meaning you remove a patch of the bowel, and then you have to suture the bowel. The suture can be done directly by stitches, by transannal stapler. This is the topic of this evening. Or you can use for a low rectal nodule the semicircular stapler, the so-called Rouen technique I introduced in 2009 in Rouen. The goal of the disc excision is a more complete excision than that provided by the shaving, but also the bowel conservation, because you will take only a patch of the anterior rectal wall and you will conserve the overall volume of the rectum and also the mesorectum and the vascularization and the innervation of the rectum. So you have to know that when you perform a disc excision, maybe you're not microscopically complete in 30 to 40% of cases, because me and Valentino Remorgida or other colleagues who perform the disc excision usually ask to the pathologist to check whether or not there are foci on the limit of the disc excision, because it means that maybe the foci are also around the disc excision. So microscopic foci may be found on the limit of the disc excision in 30 to 40% of cases. But this disadvantage when compared to the colorectal resection is counterbalanced, in my opinion, by the preservation of the mesorectum, the lack of the stenosis. So a suture in disc excision is not circular, so there is no stenosis after this suture, and also a good functional outcomes. So this is my personal experience in disc excision. So to date, I have carried out in 317 patients, and in 2/3 of cases, I used the circular stapler. And in 1/3 of cases, I used the Rouen technique with a semicircular stapler, which is not the object of the presentation today. But please pay attention to the recurrences rate, which is actually very low, because only 4 cases out of 317 presented to have recurrences on the rectum. And none of them had a stenosis of the bowel. So this is a major point, the lack of the stenosis after the disc excision. And of course, the disc excision is the alternative to the colorectal segmental resection. And as you can see, you saw in the previous slide, I routinely do the colorectal resection too, in 40% of cases. But I reserve the colorectal resection to only patients who are not longer suitable for the disc excision or for the shaving, meaning the patients who had subocclusive nodule, huge subocclusive nodule, or nodule responsible for long bowel infiltration, which is impossible to remove as a disc, or in nodule responsible for a circumferential infiltration of the bowel, or in multifocal nodules, which are very close each other. And this is not indicated to perform disc excision too close in order to avoid that the short segment of the rectum below, between two sutures may undergo a necrosis. You have to know that if you perform as serial sections by the pathologist, you may also find microscopic foci far from the nodule after colorectal resection. So I think that the colorectal resection is not microscopically complete in 10 to 30% of cases. But the recurrences rate is very low with colorectal resection, is incidental, 1%. However, when compared to the disc excision, there is a significant risk of stenosis of the anastomosis, meaning that the anastomosis you leave becomes very, very narrow and require endoscopic dilations or even secondary segmental resection, and it may happen in 8 to 10% of cases. When you have two rectal nodules, a rectal nodule or a sigmoid colon nodule, you may perform a disc excision on the rectum and a short segmental resection on the sigmoid, meaning that here you have a type 1 rectal nodule and here you have a type 2 nodule. And this combined disc excision and segmental resection allows to spare, to conservate a long, healthy rectal bowel segment. And I think it is, it should be considered in patients where the en bloc colorectal resection would be too low in order to avoid unfavorable functional outcomes. So the disc excision is very useful in these cases to treat the lower nodule. Now, how I do the disc excision using a circular stepler? I told you that I perform it in 1/3 of cases. So there are two steps of this procedure. The first one is to perform the deep shaving in order to remove 80% of the nodule and to leave on the rectal wall only a thin part of fibrous tissue. Then the second step is the removal of the disc itself using a circular stapler. The shaved area is pushed between the anvil and the shoulder, and it is removed like a calzone, where here you have the staple. So you have the staples, here you have the staple, and if you open your calzone, you have a pizza, which is here the rectal patch with the shaved area. Here you have this black, this is the shaved area. So you perform the shaving and you remove the shaved area like a calzone, like this. And behind you have a rectal suture. So I individualized 10 steps to perform the disc excision using the circular stapler. The first, just imagine that you have a type 1 rectal nodule involving the vagina, the isthmus, uterosacral ligaments, and the rectum. The first step is to cut the nodule in two parts. One is left on the vagina and will be removed after, and the second one is on the rectum. Then the rectal shaving will remove 80% of the fragment left on the rectum in order to render to have a thin rectal wall, which is fibrous because it is infiltrated, but it is thin and it is soft. Then you have to remove the fat tissue on the lateral rectal wall in order to avoid to catch it into the stapled line. So we remove the fat tissue. And then you'll put a stitch on the superior and to the inferior limit of the shaved area. Then you will introduce the circular stapler closed. So this is the anvil, this is the shoulder, the stapler is closed, is introduced at the level of the nodule. Then it is open with the anvil proximally and the shoulder distally from the shaved area. Then the nodule, the knot is performed and the shaved area will be pushed into the lumen of the rectum. Then the gynecology surgeon will pull down on the thread in order to push the shaved area into the circular stapler, and the colorectal surgeon, the general surgeon, which is placed between the legs of the patient, will close the stapler on the shaved area. Then the stapler will be fired, the calzone will be removed. Here you have the stapled line, which can be reinforced with some stitches. And at the end, we'll perform a bubble test, inflating air into the rectum and by covering the rectum with water in laparoscopy. So now I will show you these steps in a 5-minute movie. You can find this movie on the Journal of Minimally Invasive Gynecology site.
It is destined to deep endometriosis nodules infiltrating the rectum on 3 to 4 centimeter length.
This is the nodule.
The first step results in nodule dissection and rectum releasing. Deep pararectal spaces are opened and the nodule is sectioned in 2 fragments, the anterior one infiltrating the vagina and the uterosacral ligaments, and the posterior one infiltrating the rectum. The dissection is directed toward the healthy rectovaginal space located below the rectum. At the end of the step, the rectovaginal space should be widely opened, while the rectum is still notably infiltrated by the fibrous nodule on the anterior and lateral wall. The second step is mandatory, and it is represented by the rectal shaving. The rectal shaving is performed as deeply as possible into the thickness of the rectal wall in order to remove abnormal fibrous tissue involving rectal layers using a high magnification endoscopic view. As the transanal circular stapler cannot remove more than 7 centimeter cube of tissue, it results that the thinner and softer the shaved rectal wall, the greater the diameter of rectal patch that can be removed using the transanal stapler. This step can be performed using plasma energy, laser, scissors, harmonic scalpel, or other devices. During the first step, the surgeon should remove the fat tissue located on the lateral wall of the rectum. The goal is to avoid the presence of the fat tissue in the stapler line, which may result in fistula or rectal rage. The fourth step is the placement of the suture on shaved area. The surgeon places a stitch on the inferior limit of the shaved area, then a second one on the superior limit. We use a vicryl 3-0. Extremities of the thread are pulled out through the suprapubic trocar, but the knot should not be done at that moment. The suture is maintained under tension. During the fifth step, the circular stapler is introduced closed transanally. It should be lubricated, then gently pushed through the anus. We usually employ transanal circular stapler of 31 or 33 millimeter diameter. The stapler is gently pushed until the inferior limit of the shaved area. During the sixth step, the stapler is opened at the nodules level until the advil can be seen 2 or 3 centimeters above the superior limit of the shaved area. The shoulder is maintained 1 centimeter below the inferior limit of the shaved area. During the seventh step, the laparoscopy surgeon, which results in pushing the shaved area inside the lumen. Inferior and superior limits of the shaved area are now on contact, while the shaved area cannot longer be seen by the laparoscopist because it is into the lumen of the rectum. The thread is cut 4 to 5 centimeters far from the knot. During the eighth step, the colorectal surgeon placed between the legs of the patient anteverses and progressively closes the transanal stapler, while the laparoscopy surgeon pushes the knot into the lumen between the anvil and the shoulder of the transanal stapler. Anteversion of the stapler is mandatory in order to avoid catching the posterior rectal wall into the stapler. The stapler is closed, fired, then progressively removed under the laparoscopic control. Once the transanal stapler was removed outside the rectum, the colorectal surgeon opens the stapler to remove the specimen. During the ninth step, reinforcement sutures along the stapler line may be placed as deemed necessary. To do this, we use resorbable 4-0 stitches. The suture should involve the full thickness of both superior and inferior edges. At the end of the procedure, the stapler line should be well vascularized, and the fluorescein test may be helpful during the last step to ensure the integrity of the stapler line. An air test is performed by flooding the pelvis cavity with warm saline solution and inflating the rectum with air. It is destined to...
Well, now what about the large rectal nodule? Because this technique presented in the movie is suitable for nodule up to 3 to 4 centimeters in length. Because, as I told you in the movie, the circular stapler cannot catch inside more than 7 centimeter cube of tissue, which is quite small. So when the nodule are larger, you can perform either the Rouen technique using a semicircular stapler with the condition to have a nodule of the low rectum, and in this case the patch may be as large as 6 or 7 centimeters in diameter. Or you can perform a double disc excision, meaning that if at the end of the disc excision performed as it has been shown in the movie, if you think that there are some residual endometriosis on the edges can be removed with a second circular stapler of 29 millimeter diameter, and this is the double disc excision. So we recently reported a case series in GMEG journal. Now the question is, okay, we'll remove a patch of the rectal wall, but it means that the rectal wall will be shorter. What happens with the posterior rectal wall? So of course we have an excess of the length of the posterior rectal wall. However, this feature, this shape of the rectum is not related to impaired digestive function in our experience. And if you think that when you perform a colorectal resection with side to end anastomosis, you still have a pouch like this laterally, it means that this pouch is unavoidable, but probably it is not related to an impairment of the rectal function. Now, what about the immediate complications? You have to know that if you perform the disc excision, the reason is maybe not that to decrease the immediate complications rate, because the disc excision means performing a rectal suture, and the rectal suture may be related to complications. So here you have our series in Rouen until 2015, where we compared the complications related to shaving, disc excision, and segmental colorectal resection. And you can see that the fistula and the clavia and fibri complications are significantly higher using disc excision when compared to shaving, and maybe a bit less than those observed with segmental colorectal resection. So you have complications if you perform the disc excision. And this is one of our last papers published in open access, so you can read it in Human Reproduction, where we put together 1,102 patients undergoing surgery for colorectal endometriosis in order to understand the risk factor for fistula and also how we manage the fistula later. And we observed that we had a fistula rate of 3.4%. Two-thirds of them were rectovaginal fistula, 1/3 were leakages. But you can see that the risk of rectovaginal fistula when compared to shaving is quite similar between the disc excision and segmental resection, meaning that they performing a disc excision or segmental resection increases the risk of fistula 5 to 6-fold when compared to shaving. And when you perform a combined rectal disc excision with sigmoid colon resection, the risk of fistula is cumulated between the two procedures, and you increase the risk 11-fold when compared to the shaving. So the conclusion is that if you perform a disc excision instead of a segmental resection, probably is not to reduce the risk of bowel fistula. In my opinion, the reason to carry out a disc excision instead of colorectal resection is to improve the functional outcomes. So the functional outcomes means the rectal function itself. So we perform a rectal surgery, it is logical to have a look at the rectal function after the surgery. The problem is that the rectal function is a very complex situation, and which is multifactorial because it depends on the rectal shape, and here the type of surgical procedure may play a role, but also the rectal innervation, the possibility to carry out a nerve sparing technique, but also some hidden preoperative functional troubles such as the chronic constipation, functional constipation, or irritable bowel syndrome. It is well known that when a surgeon performs a segmental resection on the mid or low rectum, there is a risk, well-known risk of LARS, low anterior rectal resection syndrome, which is a mixture of constipation, anal incontinence, frequent bowel movements, and several dyschezia and several troubles, major troubles of the rectal function. And the LARS may be related to a rectal denervation, to the rectosigmoid stenosis, to a reduction of rectal reservoir when the low colorectal resection is performed, and also to the risk of fecal incontinence and urgency. And in this case, the disc excision may be helpful because the rectal denervation is usually done to inadvertent section of splanchnic nerves in large nodule of parametria. The rectosigmoid stenosis concern maybe 10% of colorectal anastomosis and 0% of disc excisions. The reduction of rectal reservoir is related to the removal of the segment of the rectum, while performing a disc excision maybe does not impact too much the volume of the rectum, even though the shape is modified by the posterior pouch. And the risk for fecal incontinence urgency is related to long colorectal resection, where the colon is gotten down to the low rectum, and the high intracolic pressure impacts directly on the anal sphincter. So when a colorectal resection is performed, the LARS may be frequent. It may be up to 40% of cases in the area of Aarhus Hospital in Denmark, where the surgeons are very, very skilled in colorectal endometriosis. So for years, I was convinced that the disc excision and the shaving may reduce the risk of bowel troubles, postoperative bowel troubles. And at the point that I carried out a randomized trial to compare, to demonstrate that the conservative surgery is better related to better functional outcomes than the colorectal resection. And I was excessively disappointed when I saw that the results were not as different as expected. Because in 60 patients randomized between conservative surgery and radical approaches, the functional outcomes were similar, except it may be for the anal continence. And I could only show that there is a significant risk of bowel stenosis after colorectal resection. However, in this, the randomized trial could be jeopardized by the inclusion criteria, because I enrolled patients with rectal lesions, rectal nodules, and I considered that the rectum is up to 15 centimeter high from the anus. And maybe the enrollment of many patients with upper rectal nodule improved the functional outcomes in the arm of colorectal resection. So maybe the trial should be repeated in only patients with low colorectal nodules, where maybe the disc excision is, may provide better functional outcomes. However, anyway, this randomized trial proved that the surgery of colorectal endometriosis is a very efficient tool to improve patients' health. Because 5 years after the follow-up, there were only 1 recurrence in 60 patients, and there was a constant improvement in pain, gastrointestinal score, quality of life, a very high rate of pregnancy, postoperative pregnancy rate 80%, and even 75% in infertile women who had surgery for rectal endometriosis, and a majority of pregnancies were natural. So the randomized trial was useful to prove these major outcomes. But I told you that I think that if you repeat the randomized trial and we enroll only patients with low rectal nodule up to 8 centimeter high, the results might be different with a more favorable outcomes in patients with disc excision of the low rectum. And here you have a very recent study, which is in review in Diseases Colon Rectum, where I enrolled only patients with low rectal nodule. All of them were managed in Rouen. And we observed that the items of the large score were better. Some of items were better in patients with disc excision, as well the percentage of patients without LARS, so with normal bowel movements, were 61% in the rectal disc excision group versus 43% in the colorectal resection group. So I think that in low nodule, you have to try to carry out a disc excision anytime you can. So people who routinely perform only colorectal resection usually say that they do this in order to reduce the risk of recurrences, because the disc excision and the shaving will leave microscopic foci behind. So I studied all this problem in patients with shaving, and I agree that the majority of them may have microscopic foci on the rectal wall. However, I still perform shaving in 30% of patients. I also observed that in up to 40% of patients, there are all microscopic foci on the limits of the disc. So maybe the disc excision is not microscopically complete in 30 to 40% of cases. However, the rate of recurrences is very low, 1.5%. But also, in patients with colorectal resection, if the pathologist performs serial sections, he may find microscopic foci very far from the nodule, meaning that if you perform short colorectal resection, particularly on the mid-rectum, you may leave this nodule behind. So even the colorectal resection is not a microscopically complete procedure. So in my opinion, the microscopic complete removal of endometriosis foci is not a realistic goal of the deep endometriosis surgery. So in conclusion, I think that the surgery of colorectal endometriosis is a new specialty. which is challenging, is complex, maybe more complex than that of gynecological cancer. The minimally invasive approach is feasible in more than 90% of cases, because during the last 2 years in Bordeaux, I have managed about 400 colorectal endometriosis, and I opened the abdomen in only 1 case. So the rate of open surgery is 0.25% of cases. You have to keep in mind when you perform a colorectal surgery that your patient is young and she will live 50 to 60 years after your surgery. So the quality of life after your surgery is determinant for her overall quality of life. The disc excision using the circular stapler is suitable, it's feasible, it's affordable for any surgeon skilled, more or less skilled in colorectal endometriosis. And it is feasible in 33% of cases. 1/3 of patients may be treated by disc excision. The immediate complications risk of disc excision is not too far from that of colorectal resection. So if you perform disc excision, you may expect severe complications rate, immediate complications rate. However, the functional outcomes may be better after disc excision when it concerns the lower rectum. And I think that a balanced use of 3 techniques, shaving, disc excision, and colorectal resection, is a hallmark of a skilled colorectal surgeon with an individualized, custom-made management and approach to his patients. And if you wish to see more procedures, there are several hundred procedures of disc excisions on my YouTube channel, on the LinkedIn channel. And don't remember, European Endometriosis League organizes a masterclass, European masterclass in February 2021 in Bordeaux. The first one was scheduled 1 day after the lockdown in Bordeaux, so it was cancelled 1 day after the lockdown. And also you're all invited in December 2021 to the 6th European Endometriosis Congress in Bordeaux. So thank you very much for your attention this evening.
Thank you, Horace. Thank you for your excellent presentation. It's really brilliant. You have so many cases, such a huge experience, and it's very, very good to see how you handle these patients, and that you remind us of how careful we should be with these surgeries and our patients. There are many questions in the chat, and I invite you all to write your questions to the chat so I can ask them to Horace. And I might start with a question, Horace, regarding the interdisciplinarity. You mentioned the general surgeon, the visceral surgeon. Maybe you can point out how you handle this interdisciplinary problem, or maybe it's not a problem, in your center, which is highly specialized, and how people should do it in their hospital or their clinic.
So first of all, you have to know that in France, the law asks that the suture on the rectum should be done by a general surgeon, because all the lawyers and the attorneys will consider that the suture of the rectum is better done by a guy trained in general surgery than by a gynecologist. I have always had a colorectal surgeon with me specifically for the time of the rectal suture. So for years in Rouen, the colorectal surgeon was spending maybe 1/2 an hour, 45 minutes with me for all the procedure on the rectum. And then with the experience, I have started performing the resection, and I call him only for the suture. So it is very important to have a colorectal surgeon with you, because you're not alone. Because if you perform a lot of cases like this, you will have an expected high rate of frequent cases with complications, because in Bordeaux, we are 2 gynecology surgeons and 2 colorectal surgeons, so we are working together. And we are managing 8 to 10 colorectal endometriosis a week. It means that every month, we reasonably expect to have 1 fistula. So this management of the fistula, to manage a fistula, you have to be very quick, and the management should be very fast. And it is over the possibilities of only one guy. So it is for me, it is impossible to think that one guy will do all the colorectal surgery, then we'll go to Congress, we'll go on vacation, and nobody is in the hospital to manage the complications. And this, so I think that having 2 colorectal surgeons, 2 skilled colorectal surgeons, is the minimal to build a center with good activity in colorectal endometriosis. So the presence of the colorectal surgeon is mandatory for the suture, for me.
Horace, there are some questions regarding hormonal treatment before and after the surgery. What is your recommendation? Do you have a special recommendation before surgery and after surgery?
So the medical treatment before the surgery, in my opinion, is useful only to reduce the inflammation. So I think that the patients with a good medical treatment for several months before the surgery is very pleasant, because the inflammation is reduced, because there is no excessive bleeding. However, in daily practice, it is not very easy to correctly block the ovaries. And now in France, the patients do not longer wish to have menopause using the GnRH analogs. So I considerably reduced the percentage of women with preparation using GnRH analogs. So I give them pills. But even with pills, now there is a kind of movement of group of women who do not longer accept to have hormonal treatment. So it happens now more and more that I perform the surgery 10 days after the periods. So it is less pleasant, because there is blood and inflammation, but it is feasible. But after the surgery, I think that the amenorrhea for 1 month may be useful, because there is a study demonstrating that performing the surgery of endometriosis and having the periods during the 10 days after the surgery would increase the risk of recurrences. Because we can imagine that when you perform the excision, there is a healing of the excised zone, and this healing increases the participation of cytokine and growth factors. And if you have blood with some endometrial cells, you may expect that the cells will may grow on the excision. So in my opinion, I always ask to patients to try to take a pill 1 to 2 months after the surgery. But it is less frequent that more and more patients do not longer accept this hormonal treatment no more. So in my opinion, it's useful, but not always possible, accepted.
Okay, thank you, Horace. There's a question from Suryadi Suwandinata, and it's about deep endometriosis surgery and its impact on fertility. Maybe you can have a short answer on that difficult question.
This is a difficult question, and this is another favorite topics of me, because I think that the surgery is a treatment of the infertility in women with endometriosis. So I routinely propose the surgery to patients who have an infertility and deep endometriosis, because as I showed in the slide with the randomized trial, after the first line surgery, you may expect up to 80% of pregnancies within 4 years, and the majority of them are natural pregnancies. So I need strong arguments to refer a patient with deep endometriosis directly to IVF without surgery. So the surgery for me is a very, very good option in patients with infertility, more or less painful, because we give them a chance of natural pregnancy. And in a randomized trial, 75% of infertile women who had surgery were pregnant, and the majority of them were pregnant naturally.
Okay, there's another question from Amit Kyle, and he would like to know what is your fistula management if it occurs. And I would like to add, what is your follow-up procedure? How do you get notice of maybe a fistula? Do you measure CRP levels, and what is the management if it happens?
Our management is very standardized, and you can have a look at the paper published in Human Reproduction, because we pay the open access, so it's available for everybody. So all the patients who had a colorectal surgery, disc excision or colorectal resection, they leave the hospital at day 3, and they have monitoring of the white cell and CRP for at least 1 week. And the CRP should continuously decrease. And if you have an increase of the CRP, the patient is prevented. She has to call the hospital, and she has to take the luggage and to come back to the hospital. And when the patients arrive to the hospital, we immediately perform a scan, abdominal scan. And if the scan, even though the scan is almost normal, we perform a laparoscopy. And we carry out a bubble test, and we inject blue liquid into the rectum in order to check if we have or not a small fistula. And not earlier than yesterday, I received patients with a disc excision last week, and she came back with CRP protein at 290, and the day before it was 22. So this patient had scan and surgery. We found only a big abscess around the disc excision, no abnormal bubble test. However, we performed a stoma because we suspected that we have a microfistula. So if you do not perform the stoma in all the patients with in a majority of patients, we should be very fast in the management of any biological symptoms. So we never have patients with peritonitis because we perform the management before the peritonitis. So increasing the CRP over 100 means that you have either an abscess or a fistula, and you have to schedule the day, the same day we have to do surgery.
Thank you, Horace. Can you hear me?
Yeah, I hear you very well.
Okay, perfect. There's another question regarding the pre-surgical management. What is the moment that you know what type of surgery on the rectum you're going to do? Already when you do ultrasound, or it's intraoperative?
There is another article published 2 years ago in Journal of Minimally Invasive Gynecology, where I showed that in 80% of cases, we performed the technique which was planned at the consultation, preoperative consultation, because all the patients had MRI. Some of them also have an ultrasound. Me, I'm not doing ultrasound, so I'm not at ease with ultrasound, but I read very well the MRIs. So all my patients had an MRI. And from while to while, we carry out a CT scan to identify lesions on the sigmoid colon or the cecum. And in some cases, we perform the endorectal ultrasound. But with all this data, I have a good idea preoperatively what kind of technique I will carry out. And in 80% of cases, I do the technique which was planned. So I need to know the length of the infiltration. There are several, so you have to read this article because it's very detailed. So the depth, the length, the height, it is important to see because each nodule on the low rectum up to 8 centimeters above the anus may be very large. We can do a disc excision using the Rowan technique. If the nodule is upper than 10 centimeters, the Rowan technique is not feasible. So if the nodule is less than 3 centimeters, disc excision, it is larger, is the colorectal resection.
Thank you. We still have some more questions. There's another question regarding the cutoff level for CR protein. Is there a cutoff level or not? The question is from Tana Usta from Turkey.
Yeah, 2 years ago, we published a paper in the British Journal of Obstetrics and Gynecology about the C-reactive protein. So we identified the threshold of 100 at day 4. It means that if the day 3 you have 122 and the day 4 you have 80 or 70, it means that you're on the right path. However, C-reactive protein 100 the day 4 or day 5, or as I told you, C-reactive protein which grows very much from a day to the day after, from 22 to 290, it means that you have either an abscess or a fistula. So 100 for me is the threshold at day 4.
Okay, I think we can do one more question. There's one from Sandesh Kadi about the pre-surgical setting, and he or she wishes to highlight why you use sometimes CT scan. How does it add to your diagnosis?
Yeah, so thank you to my friend Sandesh. So the CT scan, I was using frequently the CT scan when I was in Rouen, because I was having 3 radiologists very, very skilled in this exam. And with the CT scan, I was having very accurate information about the involvement of the cecum or the last 20 centimeters of the ileum, and also of the upper sigmoid. And now in Bordeaux, I'm carrying out less for 2 reasons. Because I do not have this guy with me. And second is that I improved my skill. So if during the surgery I find inadvertently a cecal nodule, we are able to perform a resection, ileocholic resection, in less than 15 minutes, 20 minutes. So it does not change too much the operative time. So you're not embarrassed to do so right now I reduced the use of the CT scan because it adds a new exam to patients who had a lot of exam before. And actually it does not help me too much. But intraoperatively, I routinely check very carefully all the sigmoid and the last 40 centimeter of the ileum and the cecum, in order not to overlook the nodules that I would have seen in a CT scan.
Okay, Horace, last question. What about your recommendation starting fertility treatment after disc excision or segmental resection? And what about your recommendation about delivery modus, C-section or vaginal birth?
Yeah, so if we carry out, if the nodule also involves the vagina. So I ask to patient, usually ask to patient not having sexual intercourses for 2 to 3 months and not having a speculum examination. So if they are referred to the IVF, I ask them to schedule the IVF 3 months after the surgery. As regards the delivery, the excision of the vagina is not a problem. I recommend to obstetricians to check the elasticity of the vagina at the end of the pregnancy, and if they feel that the vagina is supple, is soft enough, they can deliver vaginally. That is different for the rectal suture. If the rectal suture involves the low rectum or the mid rectum, I recommend, or the general surgeon asked me to recommend, cesarean section, because any injury of the anal sphincter may be very harmful for the bowel movement and for the anal continence after the surgery, because maybe after the surgery of the low rectum or mid rectum, if the patient is continent, maybe the balance is very fragile. So adding a new factor of incontinence may completely change the situation. And I have a patient like this with Rouen technique, who delivered vaginally against our advice, and she had anal incontinence for 2 years after the delivery, because she had instrumental delivery with a large episiotomy and maybe an injury of the anal sphincter. So I think that in the surgery of, when the patient had a surgery of low and mid rectum, the cesarean section is a good choice.
Okay, Horace, thank you so much. Many, many thanks for your brilliant presentation. It was really nice to discuss all the questions of the participants. Thanks to all our colleagues around the world attending to our webinar tonight. There are still some questions, but maybe we can discuss them next time. Thanks to you, Horace. I may just notice that on November 17th, we have another webinar with Shaheen Kazali from London, and he's going to talk about the management of ureteral endometriosis. And good night to everybody now. Stay healthy, and thanks again to you, Horace. Bye-bye, everybody.
Thank you very much. Goodbye. Good night.
Good night.